Hi, David Rosenberg here for the Psychopharmacology Institute. In this child and adolescent psychiatry smart take, we're going to look at a very understudied area, that is treating major depressive episodes in youth with bipolar disorder. Very dangerous, right? And we know that some antidepressants, for example, used in bipolar depression, are more likely to trigger mania, and some, perhaps bupropion, are less likely to do so. But study, particularly in children and adolescents, are very, very difficult. And questions come up. What do we do in children and adolescents who have a first-degree relative, a mother, a father, a brother, a sister, who have bipolar disorder? Obviously, we're going to look at what non-medication treatments can be beneficial, but we also have to look at medications. And it's not uncommon for second-generation antipsychotic medicines such as olanzapine, quetiapine, lorazepam, and others to be used. And this particular article conducts a meta-analysis where they review existing trials, only 4 in this case, of second-generation antipsychotics in youth 10 to 18 years of age that were randomized and controlled trials. And what they found was that lorazepam was the most preferred treatment for bipolar depression compared to all other medicines that were looked at. In this case, quetiapine and olanzapine. And interestingly, the lorazepam was significantly less likely than olanzapine or quetiapine to be associated with weight gain, cholesterol, and triglyceride change. And we know that weight gain, particularly in children and adolescents, is a real concern in atypical antipsychotics. Perhaps not surprisingly, youth with bipolar depression treated with olanzapine were more likely to discontinue treatment because of an adverse event. And we know that olanzapine in particular can be associated with high weight gain. I always recommend to any patients where this is being prescribed that they have an exercise and diet program in place before they start olanzapine or any atypical antipsychotic. I would add that perhaps surprisingly, there were no significant differences in changes in glucose levels among the antipsychotics. And we know that the atypical antipsychotic or second generation antipsychotics have been associated with increased risk for diabetes. So this is something to consider. Interestingly, in this particular study, quetiapine did not result in any significant improvement in depressive symptoms in youth with bipolar depression. Lorazepam treatment was also associated with less of a change in prolactin levels compared to olanzapine, but no difference was noticed with quetiapine. So what do we make of this study? Despite it having some strengths, looking at controlled trials, there are huge limitations. The length of follow-up for the study was no more than 8 weeks. And this is problematic as youth with bipolar depression continue on these medicines very long term. The authors acknowledge that that's a limitation of this study. They also included only 4 randomized clinical trials of 3 second-generation antipsychotics, and none of these trials were active comparator trials, so comparing, let's say, olanzapine to Latuda. So they're extrapolating the comparisons here, and the populations are similar, and we simply don't know this. And there's something else to realize, that head-to-head comparisons have a lot of benefit over meta-analysis reviews. And this was supported by studies in obsessive-compulsive disorder, where meta-analyses suggested very compellingly that clomipramine, a non-selective serotonin reuptake inhibitor, was superior to the other selective serotonin reuptake inhibitors like sertraline, fluvoxamine. But when the head-to-head active comparator trials were done, guess what happened? Absolutely no significant difference between the SSRIs and clomipramine in terms of effectiveness, but not surprisingly, fewer side effects were seen with the SSRIs than clomipramine. So again, Like Thomas Huxley, the eminent British biologist, liked to say, there's nothing like an ugly fact to slay a beautiful hypothesis. And we have to be cautious when interpreting meta-analyses, no matter how well the authors say the statistical analyses and how well the analyses are done, that these studies by definition are fraught with problem. Finally, I have to say that this study was funded by Sunovion Pharmaceuticals, who make lurasidone Latuda. This doesn't mean that the findings have to be completely discounted, but given the fact that the manufacturer of the compound that was reported to do the best, Latuda, in this particular study, is made by Sunovion Pharmaceuticals, and that they sponsored the study, recognition of this is needed. And moreover, editorial and medical writing support was also funded by Sunovion Pharmaceuticals. Finally, there's no statement indicated that the final content and editorial approval was made by the authors of the study. Bottom line, there is interest in terms of what to do in bipolar depression, and is one second-generation antipsychotic better than the other for particular side effects, for particular efficacy? Right now, this study provides intriguing possibilities, but further controlled study is clearly warranted, particularly in a population where the risk of lethality, suicide is so high. So we can't make any definitive recommendations at this time, other than to say that before using these second-generation antipsychotics, we have to recognize that their effectiveness still remains to be determined, particularly one versus the other. And in terms of side effects, it's incumbent upon us to do what we can do to mitigate weight gain, diabetes, other metabolic complications by having our patients and their parents know of these risks, get involved in an exercise diet program beforehand, and to monitor these patients very closely when they're on medication.